This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 78 for July 20th, 2022. We're calling this one Management of Class 3 Malocclusion with BAMP and Bollard Plates. I want to welcome all of you to the program. So we have an interesting CME activity for you this week as we explore the treatment of Class 3 Malocclusion with BAMP and Bollard Plates. And right here out of the gate, I want to break down those words so that everyone understands the broad topic. And then we'll get into specifics. But right here at the starting line, let's just define what all this means. So a Class 3 Malocclusion is a condition where the maxilla is underdeveloped compared to the mandible, or the mandible is overdeveloped compared to the maxilla. In other words, the teeth do not line up properly, and we have an underbite. There's a lot of different things that can cause an underbite, and we'll talk about those as we progress through the topic this week. One of those, though, is the surgery to correct a cleft palate. So if a child has a cleft palate and they get surgery to correct it, then oftentimes they're going to end up having an underbite or a Class 3 Malocclusion. So that's Class 3 Malocclusion. What about BAMP and Bolar Plates? Well, BAMP stands for Bone-Anchored Maxillary Protraction. So we're going to anchor something to bone and exert traction on the maxilla, pulling it forward so that over time it lines up with the mandible. And the something that gets anchored to bone, they are called, you guessed it, Bollard Plates, which are small metal plates that get screwed into the maxilla and mandible in 4 places inside the mouth. Bilaterally at the anterior mandible and bilaterally at the posterior maxilla. And we'll repeat all this as we go along, but I just think it's good to at least get a picture inside of your mind of what it is that we're talking about as we go through this. There are hooks on those plates, and a rubber band or elastic connects the mandible hook to the maxilla hook on each side of the jaw, and then we have gradual traction, which slowly moves the maxilla forward to correct that Class 3 Malocclusion. So hopefully the title of today's episode makes a little more sense now. Treatment of Class 3 Malocclusion, or underbite, with BAMP, Bone-Anchored Maxillary Protraction, using Bollard Plates. Now, you may be asking, why is this topic important for pediatric providers such as yourselves? Most of us will never be the primary managers of this condition. However, we are in a position to help families impacted by Class 3 Malocclusion. First, awareness that BAMP and Bollard Plates exist, because this is somewhat of a new procedure. It's, as opposed to traditional surgery or using headgear, this is, inside the mouth and not quite as obvious. It's not as invasive as a big surgery on the jaw. Those things have all sorts of reasons why you might not like to do that, in terms of complications and also just having to wear headgear. So identifying patients and pointing them in the right direction is an important task. Maybe in your community, you'd like to know who is doing this kind of procedure, because parents might want to know. So that's one reason. So just an awareness. But then also, as this procedure gains popularity and sees more use, these Bollard Plates are in for several months to several years. And so you may see patients in your practice with Bollard Plates installed. And these patients and families are going to have questions and concerns. Sometimes that will require a call to the specialist. But there are other situations in which you or I may be able to provide some reassurance and guidance if we know a thing or two about the problem and its management. So who are the specialists who primarily manage Bollard Plates. Well, we have 3 of them with us today. Dr. Kaitrin Kramer is a pediatric orthodontist at Nationwide Children's Hospital. Dr. Ibrahim Khansa is a pediatric plastic surgeon, and Dr. Greg Pearson, also pediatric plastic surgeon, all with Nationwide Children's Hospital. So they will be joining us shortly here in the studio. Before we get to them, let's cover our usual quick reminders. Don't forget you can find PediaCast CME wherever podcasts are found. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. And also consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know what to expect. Speaking of that credit, it's really easy to claim yours. Just listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org, episode 78. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. We offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by many professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We're also on social media. We love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And that handy contact link over at PediaCastCME.org. You can use that if you would like to suggest a future topic for the program. Also, I want to remind you the information presented in PediaCast CME is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get our expert guests settled into the studio, and then we will be back to talk about the management of Class 3 malocclusion with BAMP and Bollard Plates. It's coming up right after this. Dr. Kaitrin Kramer is a pediatric craniofacial orthodontist at Nationwide Children's Hospital and an assistant professor of dentistry at The Ohio State University College of Medicine. Dr. Ibrahim Khansa is a plastic surgeon at Nationwide Children's and an assistant professor of plastic and reconstructive surgery at The Ohio State University College of Medicine. And Dr. Greg Pearson is also a plastic surgeon at Nationwide Children's and an associate professor of plastic and reconstructive surgery at Ohio State. All 3 have a passion for helping young patients with facial differences and dental malocclusions. One such condition is the underbite or mandibular protrusion, which occurs when there is a mismatch of growth between the maxilla and the mandible. This can be treated with a procedure known as bone-anchored maxillary protraction with Bollard plates. We'll have much more to say about this condition and its fix, but first, let's give a warm PediaCast welcome to our guests. Thank you so much for stopping by today.
Thank you so much for having me. I'm excited to be here.
Thank you very much.
It's great to be here. Thank you.
Yeah, thank you very much for taking time out of your busy, very busy schedules. It is July, and July is National Cleft and Craniofacial Awareness Month. So, Dr. Kramer, what does that mean for us?
Yeah, that means that this is a really timely conversation that we're having about a therapy that we're hoping to offer to our patients pretty soon here.
Yeah, very exciting. So the title of our episode today is Bone-Anchored Maxillary Protraction with Bollard Plates. So let's break that down. I think that's kind of an important place to start. What do we mean by bone-anchored maxillary protraction?
So that's a really good place to start. So bone-anchored maxillary protraction is the technical term for these mini plates or Bollard plates that are used by screwing into the top and bottom jawbone. So they anchor that way. And what we do is we use them with elastic rubber bands that are used in orthodontic treatment to help slowly pull the top jaw forward. So it's really a combination of an orthopedic and orthodontic therapy to help improve the top and bottom jaw relationship, or that underbite that you had mentioned.
Yeah. So the Bollard plates, we actually, before we started recording, we talked about a bollard is something in the shipping world. It's like a post that you tie the ropes to that hold a boat to a dock.
That's
correct?
right. Yeah, that's how we anchor. That's how you would anchor a boat to the dock to keep it from sailing away. And that's how we're anchoring our elastics to help produce this orthopedic movement that we're looking for.
Yeah. So we just have a plate that is screwed into bone.
That's right.
And it's going to be in the maxilla, so the top part of the jaw, and that's in the back part
That's right.
of the maxilla, and then the front part or anterior of the mandible on both sides.
Yes, on both sides. So just as you described, the top plates are screwed in right near the molars towards the back on the top jaw, and then towards the front on the bottom jaw. And then all that you see are just the little hooks that come out. So the plates are under the gum, they're completely hidden, and the hooks are all that are sticking out. And that's where you attach those elastics to.
Okay. And so I think folks are familiar with the elastics or the rubber bands that are associated with braces where you're trying to pull teeth together. In this case, though, we are actually using them to move the maxilla or the top part of the jaw forward.
Yeah, so the top jaw, the whole top jaw forward. So you hook up the rubber bands or you attach them the same way you do for braces, exact same type of rubber bands. These are just stronger than maybe rubber bands that we'd use that for braces because those go onto teeth. And because we're anchored onto bone, we can use stronger rubber bands or stronger elastics, and we don't have to worry about teeth moving in a direction that we don't want them to move in.
Great. And so this is just going to slowly over time nudge the maxilla forward, correct?
That's right, yeah.
And help correct that underbite.
Right.
Why is that important to correct?
Yeah, sure. So for a lot of our cleft and craniofacial patients, they have top jaws that are smaller than their bottom jaws. And this can happen for a variety of reasons. And what we're hoping to do is that we're trying to move this top jaw forward during a time period in which they're too old for traditional orthodontic or pedic movements like a headgear, and they're too young for surgery. So we're really trying to target this age group about 11 to 14 where we can try and help improve that relationship at a time period in their lives where we didn't have many other options.
Yeah. It would seem to me this would sort of be the sweet spot of a time to do it because surgery seems way more invasive. I mean, obviously there is surgery involved in terms of putting the Bollard plates into bone, but I don't know, correcting this surgically without the little plates seems like a much bigger operation to me anyway.
Sure. I think that the idea really is that we don't have a lot of options until patients are done growing from an orthognathic or a jaw surgery standpoint. And I'd let my surgical colleagues talk a little bit more about that. Many of our patients may still need jaw surgery, but what we're hoping to do is during this time period where they're too young for that and they're too old for headgear is trying to take advantage of that and use this to reduce that or improve the relationship between the top and bottom jaw.
And nobody wants to wear headgear. So
no, right. That's exactly right.
All right. So Dr. Khansa, then who is a candidate for bone-anchored maxillary protraction?
Yeah, like Dr. Kramer alluded to, the ideal candidate is the patient whose upper jaw is positioned behind the lower jaw. So we often refer to those patients as class 3 malocclusion. That's when the upper jaw is positioned behind the lower jaw. So that's what we also call an underbite. Typically, we do the bone-anchored maxillary protraction between the ages of 10 and 13. That tends to be the sweet spot, although it's fairly flexible. The patients, if they have a cleft, for the most part, they will tend to have a cleft, and if they've had a cleft, they should have had their bone graft by then. The bone graft is what we place in the gum cleft to make the upper jaw basically one piece instead of two pieces that move independently. So their bone graft should already be done by the time they do the bone-anchored maxillary protraction. Other requirements for patients to be good candidates and to succeed with bone-anchored maxillary protraction is to be motivated. They have to actually wear the rubber bands, and so usually being motivated to have an improved jaw alignment helps. And also they should have good oral hygiene. So it's important to make sure that they're taking good care of their teeth, and that way they'll take good care of the plates.
Yeah. So cleft palate is one instance where this would be useful if there's an underbite associated with it. There are other genetic syndromes where you could also have a fairly significant underbite, correct?
Yeah, for sure. So there's many causes for underbite. definitely the most common is cleft palate. The surgery to repair the cleft and the cleft palate itself both cause the upper jaw to be smaller and to be positioned behind the lower jaw, what we call an underbite. There's other conditions. One's called skeletal dysplasia, which there's not a real anatomic reason for it, but the upper jaw can be positioned behind the lower jaw. And then we see a lot of patients with syndromes such as Apert syndrome, Crouzon syndrome. Those patients tend to have an upper jaw that's smaller and positioned behind the lower jaw.
Yeah. As I was researching this topic, in multiple places, one of the reasons for having an underbite that kept coming up was pacifiers and thumb sucking. And so, you hear folks say that can be a problem. But, in my training, we were taught it's not your thumb, sucking your thumb is not going to move bone. Is that true or false, or what's the deal? Dr. Kramer?
That's a great question. So thumb sucking over a long period of time. So we usually like to have habits like pacifier habits and thumb sucking habits corrected by age 3. So that's when I really encourage parents to try and kick that habit. Now, in terms of contributing to an underbite, I think that can vary. What you'll see more likely is that the top jaw becomes narrower and you end up with maybe a crossbite in the back. So that's when the top teeth, instead of fitting over the bottom teeth like a lid on a jar, fit on the inside. And so typically when we have prolonged use of pacifiers or bottles or thumb habits or finger habits, you can cause the top jaw to become a little bit more narrow. So you can, in a secondary thing, have something that can contribute to an underbite, but more typically, you're going to see that narrowing of the top jaw as a result of a habit.
So age 3, no more thumb sucking, no more bottles, pacifiers, all that. That's kind of the late age to do that.
I start planting the seed around 2, and then I like to say try to kick it by 3. The time where it really becomes critical is when the adult incisors or the adult front teeth start to come in. I have a little girl right now who I'm still working on a habit with, so I understand the challenge that parents have with this, but I start to plant those seeds kind of young, try to get the habit done by 3. We have things that we can do to help with that when you get a little bit older, but definitely by the time any permanent teeth come in. Yeah,
going to be important. So this is kind of a newish way of moving the upper jaw forward. Dr. Khansa, what is the traditional surgery like? If before we could use these, what sounds invasive?
Sure. Well, there's 2 options. You can go the orthodontic route or the surgical route, and it really depends on the patient. So orthodontically, typically at this age you would use face mask protraction, which is a big appliance that's mostly outside your body, so it's very visible. It requires wearing for at least 14 hours a day. And one of the big disadvantages of it is that it is attached to the teeth, not to the bone. So it causes undesirable movements of the teeth themselves rather than the bones. The other option, which we typically do when the patients are done growing, and that Dr. Kramer alluded to, so for girls that would be around the age of 16, for boys is typically 17, 18, is orthodontic surgery or jaw surgery. And that's when we go in and we actually cut the bones of the upper and the lower jaw and we move them into a new position. The recovery from that can be a little bit difficult. We certainly still do that quite commonly. But the advantage of the bone-anchored maxillary protraction is, number 1, you may be able to avoid orthodontic surgery. Number 2, if you still need to have orthodontic surgery, it would make the movement smaller in the future.
Yeah. So that in turn might make recovery a little easier?
It might make recovery easier if you can manage to operate on one jaw instead of both jaws because you were able to make the movement smaller.
Yeah. Okay. That makes sense. And then Dr. Pearson, what advantage is there then of Bollard plates over these other options?
Yeah, as Dr. Khansa said, it's a lot smaller and less invasive than a traditional Lefort surgery, which is when we move the upper jaw forward. The recovery is less. And the downtime is less in terms of dietary restrictions and return to activities that the child wants to do. So there's a lot of advantages whenever you can do something that is smaller and less invasive than a traditional orthodontic surgery.
Yeah. Is there any disadvantage to using this over the other methods?
The one disadvantage of this method compared to traditional orthodontic surgery is you might outgrow it still because the mandible continues to grow after the maxilla and is the final bone to finish growing realistically in our face, you might get a good correction and then you might slightly outgrow it. But as Dr. Khansa alluded to, then if you need a Lefort 1 as a secondary procedure, it's a lot smaller movement, which means it's a much more stable movement and reproducible and has better long-term outcomes.
Yeah.
So, or you've taken a patient from needing 2 jaw surgery to only 1 jaw surgery, which is a huge advantage as well.
Yeah. So from a outcome standpoint, though, pretty similar to traditional surgery for the most part?
We expect about 2 to 4 millimeters of movement in a front to back motion. And we can also expect about 3 millimeters of downward motion. Traditional surgery, you can do a larger movement than that. Traditionally people say between 8 to 10 millimeters is a traditional surgery cutoff. But again, that comes back to the more you move them forward, the less stable the movement tends to be. So, but we expect about 2 to 4 millimeters of bony movement with this procedure.
So good outcomes compared to traditional surgery as long as it's not a big movement that is needed.
Correct.
Okay. And then, Dr. Khansa, how do you go about placing these Bollard plates?
Yeah, so they are placed through small incisions in the gum. So all the incisions are inside the mouth. Typically, we use 4 plates. So there's 2 plates on the top jaw in the back, 2 plates on the lower jaw in the front. So for each plate, we make a small incision in the gum. Again, everything's on the inside. We go down to the bone and we screw the plates into the bone. So there's short screws that we use, typically about 5 millimeters long. And we screw them in, and then we close the incision.
So kind of like a dental implant?
Slightly different. So a dental implant is placed in a different part of the gum. This is placed higher up where the bone is, so above the teeth. But probably similar overall. You're drilling and placing screws.
Yeah.
It's a lot smaller, though, than a dental implant. So dental implants are going to be a lot wider and probably longer. These are really small screws that are used for placement. So
then do you have to wait for the bone to heal around it like you do with a dental implant, or is it ready to rock and roll like as soon as you put that thing in?
Sure. The protocol that we're using is going to be a 2-week wait period. And that's mostly because patients might be a little sore, a little uncomfortable after. And then about 2 weeks after the plates are placed, then we'll be able to get going with your rubber bands.
Yeah. Now, I'm sure that one of the first thing that parents and kids think about when you say you're going to put a screw into the bone, is this something that hurts?
It's not as painful as you might think. It's probably similar in pain to having a tooth taken out. It's typically ibuprofen will take care of the pain. They may have some swelling for a few days. So that's typically the most bothersome thing is there's swelling for about 5 days and then it gets better.
Okay.
The pain is not usually that bad. And there's 2 types of pain that we should talk about. So there's the initial surgical pain. Like Dr. Pearson talk about that.
So initially, the children are going to have some discomfort just from having the small incision made in their gingival buccal sulcus and then having the plate placed on the bone. Ironically, bone doesn't have a lot of pain fibers in and of itself. So the screws in the bone aren't the uncomfortable part for the children. It's more just getting to the bone and having that small amount of dissection. But most kids are going to tolerate this pretty well. I mean, of course, every child is different and there's going to be a little variability, but most children are going to be pretty active and feeling pretty good probably sooner than we would want them to in terms of their activities and wanting to get back to the playground and stuff like that. So, they might need a day or 2 off of things after surgery, depending on what time the surgery was and how the recovery goes. But we expect that they'll be running around pretty quickly.
Yeah, no, that is great. So you're saying the first kind of pain is like immediately with the surgery.
Exactly.
And then,
so that's the first kind of pain. And then there's the second kind of discomfort that's similar to if you've ever had braces and they tighten the wire up and you can feel it. So Dr. Kramer, what's that second kind of pain like?
So I think that patients could expect it to feel sort of like braces, just like Dr. Khansa mentioned. So a little bit of soreness, a little bit of tightness.
Tingly.
Yeah, but it should go away pretty fast. So nothing sharp, nothing intense. And after surgery, really no need for any pain management medications, I wouldn't anticipate.
Yeah.
I think kids get pretty used to this pretty quickly.
If you have a cooperative patient, and a lot of kids kids, 10 to 13, depending on their maturity level, a lot of them, can be cooperative. Is this something that's then done in an office versus an operating room?
Typically, for vast majority of patients, they go to sleep for this surgery. There are, probably in adults, you could do it in the office awake with numbing medicine. But typically, for the vast majority of our patients in this age group, they're going to go to sleep. So this is general anesthesia. Procedure takes about an hour. And it's same day surgery, so they go home the same day.
Yeah. It's a little disconcerting to hear the noises of the drill and all that business.
For sure.
And then in terms of recovery, Dr. Pearson, is this something then kids usually can go to school the next day, or do they need some time to recover?
Again, depending upon what time of surgery they had and their quick kind of their recovery, but most kids should be able to go back to school in a day or two. Again, there's going to be some restrictions on their activities, but in terms of attending classes and, studying, being with their peers, they should be able to go back to school within a day or two.
Sure. And then how long is the treatment for before they would then have to come back out,
Sure.
the screws?
That's the question I get often as an orthodontist is, when am I going to be done with this treatment after we start? So generally speaking, in order to improve that top and bottom jaw relationship, it's going to be about a year of treatment.
Okay.
And so after about a year, then what we'll look at is whether or not we've seen a good improvement, and then we'll talk about retention. So you're always going to hear an orthodontist talk about retention too. And the way we plan to retain all of the hard work that these patients have done is probably dropping them to only wearing the rubber bands at night. So if things look good, then we'll keep them in retention by wearing the rubber bands at night.
Okay. And then once we are all finished and you think, okay, we don't need these anymore, then these things come out, right?
That's
they don't
right.
stay in
Right,
there.
right.
And then Dr. Khansa, what is the removal like? Do they go back to the operating room for that?
Yeah, they go back to the operating room. It's a very similar process to putting them in. Again, a 1 hour surgery, they go to sleep, general anesthesia. We make the same incision in the gums on the inside. We remove the screws, we remove the plates, we close everything with stitches that dissolve. And typically they'll go home the same day.
You just change the direction of the drill,
That's right. Yeah.
just like at home.
Yeah.
Righty, tighty, lefty, loosey.
Yes, that's right. So in terms of just some practical information, and I think that this is important because a lot of the people in our audience are never going to actually put Bollard plates in or manage these kids in any way, except that during the year or so that they have this going on, they are likely seeing their primary care doctor. And so it is nice to sort of know what the general recommendations are. So, you can answer questions for families rather than say, oh, call your orthodontist. Not that you don't want to be bothered and you're happy to answer those questions, but if we can intervene and answer some of those, it, saves you a little bit of inconvenience. So, some of the questions I think would be on parents' minds is, what about eating? Like, do these, especially in the first couple of weeks after they're put in, are there any dietary restrictions? And then moving forward, is there anything with the diet we need to think about?
Sure. I think that the biggest thing is going to be following your surgeon's recommendations after surgery. So, and that's going to be that first couple of days that we talked about. So it'll probably be a liquid diet at first, soft, non-chewy food. So things like scrambled eggs, mashed potatoes, yogurt, and that's immediately following surgery. And then afterwards, it's really going to be about how sore or how uncomfortable a patient is. So you can expect soreness for about 5 days, like Dr. Khansa had mentioned. And so I would say probably hold off on that cheeseburger until you're feeling a little bit better to eat that, cut things up into smaller pieces. After that time, you can pretty much go to a normal diet. So again, the only thing sticking out in the mouth are just those little hooks. So unlike braces, it's not covering every tooth. So there aren't real dietary restrictions. The big thing is you can't eat with the rubber bands in place. So those will have to come out. So it'll come out when you eat, and it'll come out to brush twice a day. So every time you brush and every time you eat, rubber bands come out. And then when you're done, you put them back in.
Are the hooks sharp?
No, they're actually pretty soft. So I almost think they're a little softer than the orthodontic brackets we use, but they're curved too. So they don't have a sharp edge to them. They're hooked just so that the rubber band or the elastic can slide right over them.
Okay, so you're not hurting your fingers at all. And kids probably get pretty adept at taking the elastics out and putting them back in.
I always know a kid who's been wearing it because they can do it upside down with their eyes closed. Yeah.
is great. So popcorn is kind of an issue with braces, right? And that is a lot of kids that's a,
it's a big deal.
It is a big deal.
I like popcorn too.
Yeah. Although they get used to nibbling the outside of the popcorn and then the kernel. Okay.
They get creative.
But you can do that. You can eat popcorn with Bollard plates.
That's right. If you have Bollard plates in, you can eat popcorn, gum, all the sticky, chewy things you'd like. The only difference
is an orthodontist say it's okay to chew gum.
I do have one caveat, and that is if you have braces also, then that might not be true for you. But if you have Bollard plates only, then you can eat whatever you want.
Sugar-free gum, though.
Right, sugar-free gum and brushing twice a day at least.
Yes,
right?
very important. And flossing.
Okay. You can floss like normal too.
All right. What about sports?
Yeah, so our recommendation's really going to be probably a 2-week break before you start. And then it's going to be really important because about after that 2 weeks is when we'll start the elastics. And so that's when you're going to come in, you're going to see your orthodontist, see your surgeon, and then we'll also probably give you a mouth guard at that time too. So you're going to want to protect your mouth and your teeth the same way you would if you had braces.
Okay. And then do these hooks, do they need to be brushed? Or so when you're brushing your teeth, you just brush the hooks too?
Yeah, so the best thing is just having a clean mouth. So good brushing 2 times a day and flossing and mouth rinses and all of that's going to keep your gum inflammation down. And so that's going to keep the plates nice and healthy. One thing is after surgery, you may be on a prescription mouth rinse for a little bit of time. And so that'll be again decided with the surgeons.
Okay. And then in terms of the elastics, is it one size fits all or are there different sizes of rubber bands, and do you progress through rubber bands, or how does that all work?
Yeah, so at that 2-week appointment, we're gonna follow up with the patients, and so you'll see your orthodontist and your surgeon, and we're gonna prescribe a rubber band, and it's gonna probably be a pretty light force, and we can measure that based patient by patient, and we do that with a certain gram amount, and then after a certain period of time, we'll slowly increase the strength of your rubber bands until you're on a somewhat heavier rubber band, and then you'll be on that for the rest of the treatment.
Great. So the rubber bands really are individualized
Yes.
to the specific patient.
Yes.
So you're not going to share rubber bands with other people. No, but you can imagine kids doing this, right?
I mean, you may have similar strengths, but I would probably check before sharing or ask your orthodontist before sharing.
Maybe don't share.
Not in the age of COVID.
No.
Yeah, that's true.
It's a good, very good point. And then, so 14 hours a day that you wear these?
Yeah. So you're wearing it all the time.
Yeah.
So more than 14. So the advantage to Bollard plates versus headgear, which is worn externally, is that everybody can see that. But this no one can see. Everything is inside of the mouth. So you can wear it all the time, talk like normal, engage in daily activities without anyone seeing it. But the trick is we got to keep it on all the time.
Okay, so the 14 hours was the headgear.
Yes,
okay,
that's
I got
right.
confused.
Yeah,
there.
no, that's okay.
So the rubber bands are in 24/7.
Yes,
okay.
Except for when eating or brushing.
Okay, so you do wear them overnight.
You do wear them to sleep, yes.
Okay. Is there any uncomfortableness when you when the rubber bands are in versus when they're out? Like when you put them in, do you feel something?
Most patients that I've experienced who've had Bollard plates and used rubber bands, they get pretty used to it. Kids are pretty resilient. Yeah. I would say the first couple days, maybe it's uncomfortable, but then after that, they get really used to being able to talk and do all of their normal fun, Instagram things and whatnot with the rubber bands in place.
What about scanners in the airport? Is it going to set them off?
No, not at all. No problems with engaging in any sort of travel activity with the plates in.
Okay. And they're made out of?
They are titanium plates.
Okay. So they're okay in the MRI if you would have to have an MRI or something as well?
So I'd probably, have a conversation with radiology about artifact that may occur as a result of the plates being in if you needed an MRI. But in terms of being safe for the machine, they are okay.
It's not going to pull them out.
That's right. No, it shouldn't.
Good. And then in terms of seeing the orthodontist and following along, how often do you see these patients while they have the Bollard plates in?
Sure. We're going to see you probably every 4 weeks, maybe 4 to 6 weeks, depending. And so when we see you, what we're going to be looking for are changes in that improvement of top and bottom jaw relationship. We're also going to make sure your teeth are healthy and your gums are healthy and the plates look nice and firm. And so we'll be seeing you just regularly to keep track of all of those things.
Okay. And then some kids are going to need need braces and Bollard plates? Can those exist together?
Yeah, so that's the great thing about Bollard plates. They can exist together or they can exist apart. And so in that time frame that we're talking about, that 10 to 13 time age range, some of those kids won't have braces, but some of them might just have a few on a couple teeth, or maybe we're doing some limited movement. There's no contraindication to having braces with Bollard plates.
Okay. And then as you said, you're really making sure that the malocclusion is going away and then staying away.
Yes.
What is the time period? So if staying away, or if going away and staying away is about a year,
Sure.
How long does it take to correct it? And then how long are you watching that it's retained before you take the Bollard plates out?
Sure. So we'll probably leave the Bollard plates in for retention closer till the time the patient is done growing, really. So we may leave them because we could still use them during orthognathic surgery if they needed it, or during braces, because they are anchorage that you can use for moving teeth in certain positions if you would like to when you're doing braces. So that's going to be a case-by-case basis, but probably closer to the time when patients are done growing, and maybe even at the time that you would take out wisdom teeth, so something like 17 or 18.
Okay. So even though you may not be using them actively after several months to a year, for a lot of kids, they just stay in in case you need them again.
Right, because since they're in, you can use them and they're great for use. And let's say they're in and you notice some changes, or that patient grew, like Dr. Pearson was saying, and then we want to just retain them. So we'll have them just go back to maybe wearing rubber bands at night until it's time to decide what their long-term plan would be.
Okay, yeah, that makes sense. Dr. Pearson, what about complications to this procedure? Not necessarily in the immediate time frame, which, it's a regular surgical complications, right? Bleeding, infection, pain, that kind of thing. But what about like longer term? Are there any complications that can arise by having these plates in and leaving them in?
Not from leaving them in. Obviously, the patients will have to have good oral hygiene and make sure that they're cleaning them regularly. Theoretically, a plate could dislodge. The screws could become loose with the traction placed upon them. That would be noticeable by having it rock a little bit, which would be noticed by the orthodontist and the patient. There's a small risk of infection. It's very minimal. I mean, if you think about how many times you've had a dental cleaning and not had an infection, but because they're a foreign body, there's always a small risk of infection. But that really is mitigated by having good oral hygiene, which is going back to that whole start of the conversation. Is that's one of the requirements to having these plates, is that you have good oral hygiene leading up to it and good oral hygiene afterwards. Yeah.
And this is a reason to wear the mouth guards. I mean, one of the reasons. Does that help hold them in place, or are you just protecting teeth with the mouth guard?
You're just protecting your cheek and your teeth. Yeah.
Okay. So, and with sports, especially contact sports like football, let's say, they're pretty secure in there. Head injury is not going to knock them out.
No, because those are screwed in, and so they shouldn't be coming out.
Okay. Yeah. And if they get loose, do you just let them be loose, or
no? You could take them back to the operating room and replace them, maybe a little more distally in the bone or a little more proximally, depending upon where you can find anchorage for the screw. So it might be another small procedure, but again, it'd be one of the four, and most likely if it was going to happen, and probably a half an hour procedure.
Yeah, that makes sense. And does that happen often?
That's not very common, but anytime we put hardware in, that's always something we discuss with the patients about hardware failure.
Yeah, absolutely. So some folks may wonder, why do I need to do this at all? Whether it's the Bollard plates or whether it's the traditional surgery or the headgear. What happens if you don't correct an underbite?
Yeah, great question. So one thing to notice about the patients with an underbite, Dr. Mike, is it's not just about the bite, it's about the overall facial appearance. So a patient with an underbite, you can typically see it even if you don't look at their teeth. You can see it in the shape of their nose, on their upper lip, and the relationship between their upper and lower lip and their chin. So, and we see that a lot with our cleft patients. So, doing something to improve or resolve the underbite usually leads to a significant improvement in facial profile. It leads to soft tissue changes in the upper lip and in the nose. So it's not just about the bite. Now, repairing this can really help our patients' self-esteem long-term and quality of life.
Yeah.
The advantage of this procedure is that it can be done earlier than orthodontic surgery. So orthodontic surgery is incredibly powerful, and Greg and I love doing that surgery. But we cannot do it until the patient is done growing. usually. So that's, like I said earlier, 16, 17, 18, 19 years old. So this procedure can be done much, much earlier. So it can give you that improvement in the bite and in the appearance much sooner. Having an underbite or a malocclusion in general, where your teeth don't fit properly for a long time, that can lead to some issues with your joints of your jaw over the long term. But again, it's a quality of life issue for the most part.
Yeah. What about language and speech? Do folks who have differences in their jaw profile, does that make a difference for them?
So I would probably really have to defer to some of our speech colleagues to talk about more specifics related to that, but we can see some improvement in speech just related to the position of the jaw. So we know that orthognathic surgery, moving the top jaw forward, can improve a lot of speech just because of how the teeth are now positioned versus how they were malpositioned in an underbite. But
this is something that we want to monitor, because moving the jaw forward can also cause a change in the patient's resonance, which is the quality of their voice. And so we actually have a protocol designed where their patients are going to be seen by our speech therapist as well and monitored. We know that's even a higher risk when you talk about orthognathic surgery. What Dr. Kramer is talking about is articulation errors, where the teeth cause interference with the proper position of the tongue. That can be improved with something like this.
Yeah, that's very good to know. And then the bite itself, are there issues like with the teeth or with eating when you have a malocclusion?
Sure. So some of the changes that can happen when your teeth don't overlap in the front are going to be that a tooth needs another tooth to hit against. So if your tooth doesn't have a partner, it continues to sort of erupt, or it continues to move upwards. And so some of those changes can happen where you'll see when somebody smiles and their top jaw's behind, you'll only see their bottom teeth and you won't see some of their top teeth. And so working on improving that requires oftentimes surgery and braces. Yeah. So being able to fix this earlier alludes to what Dr. Khansa was saying, and just improving overall facial profile and improving aesthetics with your teeth.
If a tooth, obviously I'm not a dentist, I'm not an orthodontist, so some of my questions may sound a little silly to you.
No, not at all.
But if a tooth continues erupting because it doesn't have a partner, then is it sort of similar to gum regression, like in terms of like sensitivity and the danger of damaging the tooth?
Sure, not exactly the same as gum regression, but you can have risks. Like, so let's say your top teeth are way out ahead of your bottom teeth. There are studies that show that there's an increased risk for trauma in those situations. What I'll often hear patients say is that they have a hard time doing things like biting into something or being able to chew properly because their teeth don't come together. Not necessarily sensitivity the way you would have if your gums are receding, because that sort of leads to root exposures and things like that can contribute to sensitivity. Yeah. So not so much of that, but more related to just maybe increased risk for trauma and issues with eating.
Great. And so overall, as we're talking to parents about the procedure, the benefits far outweigh any risks of either doing it or not doing anything.
Sure. I think that it gives our patients a really powerful tool to really do something at this period of time to improve their teeth, to improve the relationship of the top and bottom jaw, to give them some power over a time period in which normally there's not much we can do, right? Because they either are too old for that headgear or they're too young for surgery. And so this is a good way to really work on improving some of those things. Not that they won't maybe need surgery still, but that maybe now the surgery is a smaller procedure or smaller surgery than it would have had to been.
And we're not doing this quite yet here at Nationwide Children's Hospital, or we are doing it now?
We're like so close.
Really close. All right.
Yeah, we're so close. I actually think that we're pretty much almost there. We've got a little bit of things that we're working out in terms of making sure that we get all of the plates that we need here. But we've got some patients lined up, and I'll let you.
Yeah, this is a procedure that we've actually been using Ballard plates for our Lefort 3 patients. So those are the patients with syndromic craniosynostosis whose upper midface is behind the lower jaw, and we do a procedure called the Lefort 3 distraction, where we move the entire face forward to match where the lower jaw is. And in those procedures, we use Bollard plates. But that's kind of a unique case where we're doing a surgery and using the Bollard plates to help move the bones. Where the new protocol that we're starting would be moving the upper jaw, like we talked about, without making any cuts in the bone.
Okay. And you talked about getting all the plates that you need. Are there supply chain issues with Bollard plates?
Actually, no.
Okay.
So everyone can rest assured we do not have any problems with supply chain and obtaining the Bollard plates. I just, we want everything to be in place, ready to go.
Yeah, that makes sense. Have it all organized and ready. Totally makes sense. Let's talk about the orthodontic treatment program at Nationwide Children's Hospital. I'm sure you guys take care of lots of other things as well. Tell us more about what you do.
Sure. So the orthodontic treatment program is we're housed within the Division of Craniofacial Plastic Surgery, and we really support our craniofacial surgeons. So we see kids from craniofacial team, cleft lip and palate, and any other craniofacial differences. We also see kiddos who, are missing a lot of teeth, have a lot of extra teeth. So they're going to be really more complex orthodontic cases. The thing I really like about my job and about what I do here is that we get to see kids starting at age 6 through 26. So I like to tell my patients we're in a long-term relationship because we are in it from the beginning until the end. So we support our surgeons as they're preparing for alveolar bone graft surgery, as Ibby had mentioned, and then orthognathic surgery and really everything in between. So we are in T5 in the outpatient clinic right alongside plastics. If you come see us at the orthodontic treatment program, you might see me or one of our other amazing craniofacial orthodontists, Dr. Morris or Dr. Mercado.
Great. And to be an orthodontist, you're dentist first, and then you do orthodontic training after that. Is that right?
That's right. Yeah. So you do 4 years of dental school, and then you do orthodontic residency. So that can be either 3 years or 2 years. And then I went on and did a craniofacial orthodontic fellowship. And so that's where I spent a year focusing on treating children with craniofacial differences in cleft lip and palate.
Great. And from your passion, I can tell you love your job.
I do love my job. And I will say that there are many orthodontists who see a lot of our patients out in the community and who do a lot to support our patients and general dentists and pediatric dentists, as well as my partners who I work with. And so it's really a team, and it takes a family, and we've got a really great team and family here.
That's fantastic. And then Dr. Pearson, tell us about plastic and reconstructive surgery at Nationwide Children's.
Yeah, one of the things with the Department of Plastic and Reconstructive Surgery at Nationwide Children's that we're most proud of is the multidisciplinary care that we're able to provide a huge variety of patients. We've mentioned the Cleft Lip and Palate Center, which is headed by our chairperson, Dr. Richard Kirshner. We have the Center for Complex Craniofacial Disorders, and these are both multidisciplinary care teams. We have a vascular anomalies clinic, which involves a whole host of other specialties. We have our adolescent breast program, and we have the hand and microsurgery / brachial plexus and peripheral nerve surgery with Dr. Bjorklund and Dr. Amy Moore. So we provide a huge gamut of services and opportunities to help patients, which is what we all enjoy. And we get to do this in a multidisciplinary manner, which is just wonderful for us and for the patients in terms of their care.
Yeah, absolutely. So some of the microsurgery stuff is pretty interesting, right?
Yeah, Dr. Bjorklund does an amazing job with some of the things that she does.
Yeah. And then you guys also are involved with the hand clinic here. True, correct?
Dr. Bjorklund, yeah, she's with Drs. Pop and Dr. Samora. So they do a multidisciplinary hand clinic, including congenital and pediatric hand. Yeah.
So lots of stuff that your department is involved with. And I'm going to put a link in the show notes to both the orthodontic treatment program at Nationwide Children's and the plastic and reconstructive surgery program at our hospital. And those will be in the show notes over at PediaCastCME.org. And then don't forget to get your Category 1 credit for listening to this podcast. It's easy to do, and after we're done with the interview, we'll explain what that process is. But before we do that, I just want to take time to say again thank you to Dr. Kaitrin Kramer, and she's pediatric orthodontist here at Nationwide Children's, and Dr. Ibrahim Khansa and Dr. Greg Pearson. Thank you, all of you, for being here today.
Thank you so much for having us. It's been a pleasure.
Thank you.
Thank you, Dr. Mike.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks to Dr. Kaitrin Kramer, Dr. Ibrahim Khansa, and Dr. Greg Pearson, all with Nationwide Children's Hospital. Don't forget you can find PediaCast CME wherever podcasts are found, or in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, CME information, our terms of use agreement, and that contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. You've listened to the podcast, and now be sure to claim your free Category 1 continuing medical education credit. It's an easy thing to do. Simply head over to the show notes for this episode at PediaCastCME.org. You're looking for episode 78, and you'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Super easy, right? And it's free. And again, we offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also, don't forget about our sibling podcast, just plain PediaCast without the CME. It's an evidence-based podcast for moms and dads. Lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed. Keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.